Hello, everybody. It's Pam Leahy, the student coordinator for CRWDP, and we are very pleased to have Dr. Christina Hackett with us today, talking about her PhD research and specifically factors influencing the mental health of community mental health workers in NAN. And Christina was a PhD student. She graduated from McMaster University in the Health Policy Program in 2017, and she is now working with the Social Research and Social Demonstration and Research Corporation in Ottawa as a senior research associate. And she very kindly agreed to give us her time today to share with us her research in a northern community. So I will let Christina take it away.
Thanks, Pam. Yeah, so good afternoon. I'm Christina, and I'm going to be presenting, as Pam mentioned, work that I did as part of my doctoral thesis. Exploring factors that influence the mental wellness of community health workers in Nain, Nunatsiavut. So I should mention that this work was a collaboration between me and my doctoral committee members who I acknowledge at the end of the presentation, as well as in partnership with the Nunatsiavut government, and I'll talk a little bit more about that in a bit. So, as a non-Indigenous person doing research in any area pertaining to the health and well-being of Indigenous peoples living in Canada, I'm very mindful of the importance of positioning myself in relation to this work. So I came to this work because I lived and worked in Nain, Nunatsiavut, as a mental health clinician for the Regional Health Authority and in partnership with the Nunatsiavut Department of Health and Social Development's mental health workforce. So I'm mindful of always socially locating myself within research because of the sort of legacies of harmful research practices with Indigenous communities and the historical exclusion of Indigenous peoples and communities and ways of knowing from the whole research process, from shaping research questions and priorities, as well as sort of the devaluation of Indigenous ways of knowing. So, you know, this work, as I'll speak to, was done in partnership with Nunatsiavut, and it was guided by the Pili-Tiknik Partnership Model for Community Health Research in Inuit Communities. It was important and is important to formalize the process of prioritizing Inuit values in the research approach, as Nain is an Inuit community. And the model provided a set of guidelines and considerations for me in my approach to working with DHSD and the Nain community members in this capacity throughout the course of the study. So these 4 Inuit concepts form the basis for my own reflection regarding the research process, as well as how I approach data collection, analysis, and interpretation. And this was done through ongoing consultation with the Research Advisory Committee, comprised of Nunatsiavut Department of Health and Social Development staff and decision makers. So really briefly, these 4 principles emphasize the importance of relational connectedness in Inuit communities, the power of storytelling and Inuit knowledge, the importance of having a holistic worldview, and the concept of being good and doing meaningful work that benefits communities. So, as sort of touched on, there's been multiple policy legacies that have and continue to create barriers to Indigenous people's access to important determinants of health and well-being, including healthcare services. So Indigenous self-government and stewardship over policy, including health policy and service planning, are important positive determinants of Indigenous health, as well as cultural continuity. And so given the barriers Indigenous peoples face in accessing healthcare in general and the barriers faced by those living in remote northern communities in particular, Indigenous organizations have really emphasized the need to train Indigenous healthcare professionals and strengthen recruitment and retention of existing Indigenous healthcare workers. So again, in remote northern communities, community health workers are considered to be vital to the community-based and culturally grounded healthcare service delivery that I just mentioned, because they identify in multiple ways with the populations that they serve within the community. So community health workers in general, have various levels of professional education and training. They can be unlicensed and unregulated health professionals, as well as licensed practical nurses, for example, registered nurses, or clinically trained mental health clinicians. In Canada, they can be integrated into formal healthcare systems or can practice independently. And again, they serve as frontline healthcare professionals and work with populations in marginalized or isolated communities. They've shown to be effective in different parts of Canada, as well as the US and other high resource health systems, in reducing health inequities through outreach and community programming, particularly in communities facing health disparities. So they do this by bridging to outsider service providers, which is especially important when they're, in remote contexts, when there is intermittent access to physicians and nurses in the community. So despite the integral role that community health workers can play in providing culturally responsive care in remote communities, there's a lack of research examining how to strengthen and sustain this health human resource in these settings. And little is known about what factors influence the mental wellness of community health workers within these contexts, or about their experiences in accessing mental health supports if and when they're needed. So in general, the healthcare workforce in Canada has some of the highest work injury and absenteeism rates, driven by things like workplace violence and high levels of physical and emotional stress. Particular barriers exist for healthcare workers, and this is pretty well documented, in accessing mental health supports. And some of the work that has been done has shown that there's kind of a particular stigma to healthcare professionals accessing mental health resources, sometimes a lack of resources, and barriers in terms of organizational culture or leadership around normalizing mental health promotion and the need for services. So significant barriers have been identified for healthcare workers in urban environments. Less is known about how and if healthcare workers in rural and remote communities access mental health supports to prevent short or prolonged absences from work as a result of mental ill health. And again, more broadly in Canada, in 2013, the National Standard for Psychological Health and Safety in the Workplace was established, outlining a systematic approach to develop and sustain a psychologically healthy workplace with a focus on mental illness prevention and mental health promotion. So the development of the standard recognized that the psychological health and safety of workplaces and the mental wellness of workers are vital to the sustainability of workforces. Given the development of this national standard and that the sustainability of the community-based healthcare workforce, and indeed many workforces, depends on the health and well-being of its workers, it's important to understand how to maintain or improve the psychological health and well-being of community health workers in remote contexts, in particular because in these contexts, the health and well-being of healthcare workers is tightly interwoven with the health and well-being of the broader community. And so this was really the rationale leading up to working with the Department of Health and Social Development in Nunatsiavut to to develop these research questions in order to understand, how do community health workers maintain and improve mental wellness at work? What are the barriers and facilitators to workplace mental wellness, as well as to accessing supports to improve or maintain mental wellness at work, and to what extent do the perceptions of healthcare workers in this context align or not with different job authority levels. So to what extent do frontline staff, community health care workers experiences mirror those of their supervisors at different levels. So a little bit about where the study took place. It took place in Nunatsiavut, where again I lived and worked in mental health. Nunatsiavut is one of 4 self-governed Inuit regions in Canada, and Nain is its currently northernmost inhabited community, as well as its most populous. So it has roughly 1,300 residents. 4 of the 5 coastal communities in Nunatsiavut are accessible by flight or by boat in the summer, and not by road. So most of the communities are, for the majority of the year, fly in and fly out. So really we set out to explore how community health workers, or as they're known in Nunatsiavut, program support staff, their managers or team leaders, and higher level supervisory staff who are director level or above, including policy and decision makers within the department, maintain or improve their mental wellness at work. And we really wanted to do this from a research perspective, but also, to provide insights into factors influencing DHSD worker mental wellness that could be actionable and usable by DHSD in informing, next steps. So just a little bit of background, because I am a health policy person, about the Organization of Healthcare in Nunatsiavut. So the Department of Health and Social Development, or DHSD, is one of 7 Nunatsiavut government departments, and it has jurisdiction over 6 health-related program areas. So these are non-insured health benefits, mental wellness and healing, communicable disease control or public health, home and community care, healthy lifestyles, and healthy children and youth. So DHSD is located within a provincial health authority in Labrador, and clinical and acute mental health and health services are delivered by the regionalized provincial health system still, so within community clinics by nurses. DHSD community health workers provide, these services, so public health, childcare, social health, and mental health programming. And at the community level, the number and type of program support staff varies based on population and human resources available. So the number of DHSD community health workers is the largest in Nain because it has the biggest population. And so these are the sort of 3 job authority levels that exist within the department and that were included as perspectives in the study. So we use the partnership model as an overarching approach in combination with a case study approach. And so we used an explanatory single case design and obtained ethics from the Hamilton Integrated Research Ethics Board, as well as the Nunatsiavut Research Ethics Advisory Committee. We conducted semi-structured interviews with staff representing, the 3 job authority level perspectives, so program support staff, team leaders, and supervisory staff within the DHSD. We also drew on peer-reviewed documentary sources such as peer-reviewed and gray literature policy documents and media sources from the region. We developed theoretical propositions for which factors could influence community health worker mental wellness, and then completed multiple rounds of iterative analyses. So really briefly, and I'll go over it a little bit more in a minute, but we conducted a big literature review that informed the development of the theoretical propositions. So the factors that influence mental wellness plausibly for mental health workers in a remote northern setting, and then conducted interviews as well as compiled other sources and completed analysis and consultation with the Research Advisory Committee, comprised of New Natsiava community members and DHSD staff, was ongoing throughout. So they helped to shape the, as I mentioned before, the research questions, but also the interview protocols, pointed to documentary sources and helped with interpretation and kind of shaping the study in general. So the definition of the case, or how we define the case, was community health worker mental wellness and experiences of support in a remote Indigenous community, and more specifically Inuit community, and just using the sort of case study typography here. We wanted to use a case study to identify lessons learned to improve practices. It also is sometimes allows for transferability of findings to other similar contexts, while allowing for context to be integrated into the study design and findings, which is really important because we really wanted to understand how context, I guess, mattered in this case. So again, we developed these theoretical propositions prior to data collection, and it's, as it can kind of establish analytic rigor and external validity in single case studies without a kind of whole host of cases to compare with. In this study, there were many areas of scholarship that helped to understand the context as well as factors influencing mental wellness. So these included Inuit conceptualizations and literature related to Inuit health, determinants of health, well-being, and ways of knowing, health, human resources in Indigenous and rural and remote contexts, occupational, psychological health and safety, trauma-informed care and policy, and organizational climate and culture. So this is where we conducted a massive lit review to identify factors that promote occupational health and safety, factors related to burnout, stress, and role strain, factors related to work and health more broadly, and then, of course, contextual factors, such as levels of exposure to trauma in the community, at work, and the accessibility of healthcare resources in general. So the factors that emerged, or themes that emerged from the literature, mapped onto 4 categories of factors: job role, organizational, individual, and community. And so job role factors included different authority levels. So for example, workers at higher authority levels may experience less stress related to conflict and may have access to better benefits than those at lower authority levels. In this case, the perception of program support staff in the community, both as workers and as well as community members in a tightly woven setting, and then the psychological demands and rewards of specific roles. In terms of organizational factors, again, organizational culture related to policy surrounding trauma, supervisor or leadership buy-in to psychological health and safety processes, as well as organizational communication, at the individual level, embeddedness within the community, again, individual or personal exposure to trauma, and then experiences of stigma related to help seeking. And then, really being mindful that collective trauma and trauma at the community level is an important factor. And so current levels of trauma and loss in the community, and how that influences worker mental wellness in the context of a remote community. So these are the data sources. So again, just reiterating that peer-reviewed sources were included to develop the theoretical propositions. They were also included in the analytic stage to triangulate themes that emerged from interview data as well as other documentary sources. There was no overlap in the peer-reviewed literature that was used to inform the theoretical propositions, and the scope of and the triangulation stage, the scope of the peer-reviewed sources in the analytic stage really focused on any peer-reviewed literature pertaining specifically to Nunatsiavut or to remote Northern Indigenous community mental health workers. So the interviews really drove the majority of the data and the themes that emerged. And so participants were included or staff were included who were working for DHSD at the time of the research. So 25 of 54 DHS staff responded, indicating interest in participating in the interviews. And so they were all DHSD staff who were either living in Nain or who were supervising staff in Nain were contacted by the DHSD advisory committee to explain the study and say that if they were interested, they could contact me. And so about 25 individuals did, and 22 interviews were completed. One participant became ineligible. They left DHSD, and 2 were unable to be interviewed due to family circumstances. So in the end, we had 12 community health workers participate, 14 leaders, and 6 supervisory staff. So in terms of analyses, before coding the interview data, we analyzed the results of policy document and media searches to code contextual factors, and then coded the interview data iteratively in stages. We used the prior theoretical propositions as a first sort of go through with coding, and then a more nuanced coding framework emerged with some themes coming from the data. And again, an ongoing process of reflection and consultation throughout the analytic process. We, in findings, included themes that had support from 2 or more sources. And we also looked at themes of alignment and divergence across the perspectives and data sources. So we found a complex set of interactions between job role, organizational, individual, and community factors, which influenced DHSD staff's mental wellness at work, both positively and negatively. The degree to which workers were embedded in the community influenced the degree to which these factors influenced mental wellness. And they were supported by the published and gray literatures, as well as policy documents, in addition to the interviews. both job and non-job related exposure to trauma, as well as organizational communication, were major influences on worker mental wellness, as was perceived organizational response or non-response to trauma exposure of frontline staff. And so I'm just going to walk through the 4 different factors and some of the themes that emerged, talk about the divergence and alignment, and then discuss some of the implications. But first I'm going to take a sip of water. Okay. So in terms of job role factors, all perspectives, so community health workers or program support staff that were frontline workers, team leaders, and supervisory staff all felt that trust, the sense of trust between coworkers, and the pride in delivering programming that helps the community were a major positive influence on their mental wellness at work. For supervisory staff, feeling challenged in their role and having no day be the same was also a positive influence on mental wellness. However, for frontline staff, feeling competent in their role was really more important, and feeling as though they had the training and they knew what to expect on a day-to-day basis. On the barrier or negative side, in terms of mental wellness, exposure to trauma within a worker's role was a negative influence on mental wellness, and for team leaders, especially those living in the community, an increased scope of role without adequate training was a barrier to mental wellness. And so just to share a quote from one of the frontline staff regarding exposure to trauma within work. I'm starting the quote now, and I think it was because I was getting re-traumatized by people's lives through my job and I didn't know where to go. So I just kept it to myself, and it was really tough. I got sick because my mental health was not good. I was in and out of the hospital. So just in terms of organizational factors, one frontline staff said, "It's very positive and easy to work together. I'm not scared to approach any of my colleagues. Everybody takes care of each other. We're a very tight-knit community." And so there was a culture of support felt by all perspectives between coworkers and from supervisors or colleagues. All workers felt training opportunities provided by DHSD really helped in terms of mental wellness and coping and feeling confident at work. And all appreciated the culturally appropriate benefits, such as added annual leave for hunting, fishing, and gathering provided by the Nunatsiavut DHSD. Program support staff and supervisory staff felt that psychoeducational programs offered during work time were really beneficial for mental wellness. Supervisory staff pointed to the very generous benefits that, from their perspective, Nunatsiavut offered staff. On the negative side, a lack of trauma-related policies was cited by all workers as being a barrier to worker mental wellness. And for frontline staff, so program support staff and team leaders living in the community, a lack of formal supports for available for workers when they were exposed to trauma in the community was a theme that came up, and a lack of resources and awareness of how to obtain resources to deliver programming from supervisors living outside of the community was another barrier to mental wellness at work. In terms of individual factors, worker embeddedness and meaning the amount of time workers had lived in the community, whether they had been born there, and how long they had worked in the community in their role, really played really influenced both positive and negative factors related to mental wellness. So on the positive side, embeddedness increased a sense of connectedness with coworkers and with community members, and really highlighted the informal supports available. All perspectives felt the land and personal coping strategies were really important to for each individual to facilitate their mental wellness, both at work and outside of work. In terms of sort of negative factors, worker embeddedness could compound trauma, and also workers were very aware of coworkers' personal challenges and trauma they might be experiencing, and so had concerns about debriefing or consulting with coworkers, as they did not want to re-traumatize colleagues. So sort of a bit of tension between having informal supports and feeling really connected, but also feeling a concern about wanting to protect those around them. Program support staff and team leaders on the ground felt there was some stigma around accessing formal supports that might be available in the community for them or internally with DHSD as a result of a lack of anonymity or negative experiences in the past and a lack of confidentiality. So in terms of community factors, community resilience and the strength of informal support networks were found to be really important. And then again, community levels of trauma and a lack of formal mental health services or a really sporadic ability to access formal mental health services in the community was felt. And so one program support staff said, the trauma is so huge here, it's kind of scary to face it. It's a big thing, even though we need to start small. And they have done some steps with some staff, but I think it needs to be something ongoing. That's why I mentioned at the beginning about standards and supports, not only in DHSD, but in the community. Because when you look at other agencies, whether it be the RCMP or the clinic, and even the teachers, when something traumatic happens, they have teams come in. We just don't have that. So this is sort of the conceptual framework or theoretical framework that we developed based on all of the analyses and data collected, and the bold writing in the sort of under the different factors signifies that all three perspectives felt that or supported that theme, and the italicized writing signifies sort of one or two perspectives supported that and the other did not. And so really what came up again and again is that, again, embeddedness in the community, being located in the community, and then the way that knowledge and information was communicated and shared across job authority levels and just among staff in general, organizationally, were really strong, I guess, influencing factors on the degree to which the job role, organizational, individual, and community factors in turn influence worker mental wellness. So this is just to sort of provide an overview of the things that really facilitated worker mental wellness that may be relevant to other contexts. So, it very broadly having a clear understanding of roles and responsibilities for frontline staff is you know, one would argue universally beneficial for mental wellness. Having adequate training, feeling a sense of support and a part of the team, and having leadership buy-in for workplace health and mental health, as well as formal policies that outline access to mental health service for workers. Again, sort of across multiple contexts, worker exposure to trauma and vicarious trauma, higher levels of stress and burnout among workers, stigma, and the normalization of symptoms of burnout, stress, and trauma exposure, all sort of were, you know, are barriers to worker mental wellness, community health worker mental wellness. In terms of what's unique to this context, you know, we found a lot of intersections between worker embeddedness and Inuit values and culture. So the importance of relational ways of knowing, and how that, I guess, intersected with job role identity. Workers serve the community full time, both in and outside of work, and that both created a sense of pride, but also role strain. Relational connectedness and professional boundary setting was another tension. Balancing individual self-care with the community-focused nature of Inuit culture, as well as, you know, so I guess some of the professional boundary setting approaches that are typically used in non-Indigenous models of mental health or health work don't necessarily apply or are at odds with the values of some of the community health workers. So that was, I guess, a challenge. And then resilience, coping, and trauma exposure played a big role in terms of influencing mental health and wellness, both what was happening in the community as well as exposure at work. And then that kind of interplaying with the level of formal and informal supports available. And so really briefly, different workers' perspectives had diverged on some points. So higher job authority levels of supervisory staff tended to have more positive perceptions of the supports available to staff. The attribution of worker mental wellness to community trauma, there tended to be a bit of a divergence with supervisory staff seeing that more as an individual reality versus, you know, frontline staff and team leaders really feeling that community levels of trauma influence their wellness on a day-to-day basis. And then the need for formalization of mental health supports within the organization, with frontline staff really wanting more formal supports available to them. So really briefly, you know, this addressed a gap in the literature, and the framework developed, and it's still being refined with Nunatsiavut, but it takes into account multiple perspectives and expands upon existing theories and explorations of workplace wellness for community health workers. The limitations, you know, the theoretical proposition groupings, while we did that in partnership with Nunatsiavut, are not fully grounded in Inuit ways of knowing. And there were practical limitations on collaboration at certain points, including, you know, the kind of coding and analysis, just because of the sensitivity of the data from the interviews. And we didn't overtly conceptualize mental wellness, as we asked in the interviews about each person's kind of conceptualization of mental wellness. So we did find some actionable areas, and I know that I'm sort of running out of speaking time, so I'll just quickly say, you know, having some more formal training for new hires in the organization, developing some organizational policy related to connecting frontline staff with formal mental health supports, particularly during times of crisis or crisis response in the community, as well as a formal process of debriefing, and then having some leadership initiative to address stigma within the organization, which, you know, I think they were very mindful about doing, especially in participation, participating in this work. And you know, contextually really understanding the rapid change of the organization, growth of the organization, and related kind of policy development within DHSD in the context of historical trauma and all of the changes that have occurred over the past few decades in the community was really important. And so finally, you know, thinking about how best to support workers who are from communities and who know their communities and are providing culturally responsive care is really important. And so, you know, at the end of every research presentation, work is needed, but I think understanding how self-governed areas who are taking, you know, stewardship of health services and having a better understanding or a more fulsome understanding about how best to support those workers in terms of mental wellness with limited access to the formal supports that are available in more urban settings is pretty important. And I just want to acknowledge that this work was done in collaboration with my co-authors, who are my doctoral committee, as well as Michelle Wood from the Nunatsiavut government, and in partnership with the Nunatsiavut DHSD. Any questions? I'm sorry, I went a bit over.
That's perfectly okay. Thank you so much, Christina. So Sue asks if you can give us a few examples of what you heard were trauma within role and trauma within community, and also types of historical trauma still having an impact.
Yeah, I always I always hesitate to be the person to talk about the trauma being experienced in the community, but essentially within role exposure to trauma were things like supporting families who had just experienced traumatic deaths, removal of children, or I guess violent incidents. And so because a lot of workers you know, were related to or knew many of the families they were working with, and also would have experienced that loss, that would be sort of how the embeddedness kind of compounded that. So it's both a personal and role related exposure to trauma, if that makes sense. And so really any individual incident, like a death by suicide or other death, even if it wasn't a traumatic death, really impacted the community. And I think those incidents are some of the manifestations of the historical trauma. So a lot of the workers would have themselves the older workers would have had an experience of residential school themselves. So it's really not that long ago that was being experienced. And so that is still part of the workforce's experience. I don't know if that answers your question very well, but.
Well, it seems to be a really extensive answer to the question, so thank you. She can certainly, the attendee can certainly send back something if it's not. So let's move on. Heather Fowler says, thank you for the presentation. It was great. Margaret echoes that. She said and added that it was beautiful photos. I agree. They were beautiful photos.
Thank you.
Thank you. What Margaret also asked, actually, she has a few questions, so let me get to them. What proportion of community health workers are born locally?
Sorry, say that again, Pam?
What proportion of the community health workers are born locally?
So that's a good question. In Nain, so of the 12 that were interviewed, they were all either from Nain or from another coastal community.
Okay.
Yeah.
And how are the community health workers trained?
Yeah, so some of them take, so there's a lot of in-house training through the Department of Health and Social Development. They do offer very regular trainings on, trauma and addictions, or and for some of the community health workers' roles, like in the daycare or as personal support workers, they receive more formal training. Certifications that they need in order to do that work. And there's some variability. There are a couple of public health nurses living and working in the community as well. So it really depends on the role, but kind of on the job, formal within the organization, and then some formal education as well outside of the organization.
Okay. Thank you. Margaret has another question that's really actually one that I would like to know too. So maybe we'll leave that to the end because it sounds like a good closing question. But she also asks, what kind of stigma do community health workers face?
Yeah, I mean, it's a very small community. So for example, when, experience that was shared shared by different people in different ways, but it's essentially, if you want to go down to the mental health clinician who is not working, who's not your coworker, who's working for the province, everybody can see that you're going down there. And so people will have experience, like people sort of saying negative things to them about, oh, are you, what's wrong with you? So sort of that very direct stigma. And then also an internalized stigma of, I can't be seen getting help for my mental health because I'm supposed to have it together because I'm the health worker who's helping other people who are struggling in my community. So there's sort of two layers to that.
Right. Okay. Thank you. Heather asks if you can say a little bit more about the kinds of supports and training that workers felt would be more effective in helping them cope, and how, in a practical sense, organizational development can take community intergenerational trauma into account.
So some of the training that was available was, and that people felt really did help was, there was some psychoeducational training, like formal training and a course that was offered to staff, and that staff were able to do during staff time. So that's a very direct kind of training for coping. There was also, I think, a lot of the, in terms of job role, there were a lot of frontline staff who just felt that they didn't know what they were supposed to be doing every day. And so I think just some very basic orientation to the role. And given the spread geographically of the region and where all supervisors are located, it's difficult to do that if your supervisor isn't face-to-face all the time, right? Or very regularly. So I think having sort of a more formal orientation was something a lot of people said that they wanted. I think it's the second part of the question about intergenerational trauma is a really hard one for me to answer. I don't know that I'm the person to try to address that, but I think one of the things that a lot of, especially older frontline staff who had been at DHSD for many years and who had a more kind of direct exposure to residential school felt was that their lifestyle had changed so much. There had been relocation in their lifetime. And so the growth and rapid expansion of DHSD and the kind of formalization of more and more policies felt a little bit, was difficult. So that added kind of change in their workplace along with every other facet of life was difficult. So I think, I don't know how to sort of address that other than, you know, being mindful of that. And
right.
Yeah, anyway.
I think you did a great job. As a non-Inuit, which brings me actually to a question I would like to ask before we get back to Margaret's questions that we could use to end the session. And that is, as a newcomer and someone who is not part of the community, how did you manage to recruit? How did you start that process, and were they receptive, and were there challenges to doing that?
Yeah, I was concerned about the recruitment through the advisory committee because most of them were supervisors. So my initial concern was, I don't want people to feel that they have to do this as a part of their job. So, but I had worked there for almost 4 years in, you know, in an office where I knew a lot of the DHSD staff well. And so there was not really an issue with recruitment.
Okay.
When I showed up in the community, there was actually at one point a lineup to kind of do the interviews. So it was nice. It was, I think people wanted to talk about their experiences.
Right. Well,
yeah.
That is nice to have that recruitment go smoothly.
Yeah.
So actually, that's a great segue into Margaret's question. And that is, how did you come about to live in and work in Nain?
Well, I was living and working in Vancouver in mental health, and I was sent, it's not a very exciting story, I guess. I was sent the job ad, and I went and visited the community, and I was in my mid-20s, and it excited me, and I had never been to Labrador, and I had no idea about you know, the way of life in that part of the country. And so yeah, I went and visited several times and met everybody and then took the job. And yeah, that's how that happened. Okay.
And how was your reception in the community, that the integration into the community?
It was so I was very busy very quickly because I was hired because there was a state of emergency called in the region due to some incidents that had occurred in the community, and so they were calling on the province to hire mental health staff to have them in the community, because prior to my position being posted or set up, people had to fly out of the community for counseling. Mm-hmm. So people were very happy that there was someone there. There were, you know, it was a very formative experience to be the outsider, and I learned a lot from doing that. But I will say that I formed really strong ties with the community, and I go back often. Well, you know, at least a couple of times a year. So.
Oh, okay.
Yeah. I don't know, but it was definitely a major eye opener, and yeah.
Right. Okay. Well, we actually have 3 minutes left, so I was hoping I could sneak in another question since I don't see any questions in the lineup. And that is, if you can you explain a little bit more about what you mean by Inuit ways of knowing?
Sure. So there's an emerging kind of formalization of Inuit epistemologies and approaches to thinking and to research, but a very, I guess, concrete example is when I would be invited to go off skidooing with like a family from Nain, like onto the sea ice. You know, I don't know, I might be going on a tangent here, Pam, but my thing is like, how long will it take to get there? How many kilometers will it be? You know, how thick is the sea ice, and what direction are we traveling? And you know, the sort of Inuit family, like the head harvester was like, Mark, he was like, you're asking a lot of Halunat questions, like white people questions. And so there, you know, just sort of the sea ice is safe. We're going this direction and we'll be there in a bit. And there, so I don't really know, I can't really explain. It's just a different way of looking at the world, and one that's really valuable. So yeah.
Well, that's really fascinating. Thank you for sharing that. There's so much more I could ask, but I know that we're out of time and everybody needs to get back to work. So I want to thank you so much for sharing your research and your experience. Sue says, she just came on and she said, so great to hear about your experience and the local experience, since it's a place most of us will never visit. Valuable research, great presentation. And I want to echo that. It was a great presentation. Thank you everybody for attending. And if anybody wants a certificate of attendance, please let me know. Any other questions, you can email me. Also, the recording for this will be available probably within a month. You can check either the YouTube channel that we have or the CRWDP website. And lastly, I want to give a great big thanks to Dr. Hackett for sharing her time and her research with us today. So thank you.
You're welcome. Thanks so much for giving me the opportunity.